Greetings everyone. Today we are going to see on the topic regenerative endodontics. Regenerative endodontics by Murray et al. Is defined as a biologically based procedure which is designed to replace damaged structures including dentine and root structures as well as cells of the pulp dentine complex. Regenerative dental procedure have a long way going back to 1952 when Dr. B.W. Herman reported to the application of calcium hydroxide in case of vital pulp amputation. There are two basic terms which are used, that is revascularization and regeneration. The term revascularization was first used by Eva et al. In 2001. Later, revitalization instead of revascularization was proposed because this term was more applicable as the tissue regenerated in the canal space were not only blood cells but also soft and the hard tissues. The term regenerative endodontics was adopted by AAE, that is American Association of Endodontists, in 2007 based on this tissue engineering concept. Basically, the necrosed tooth can be treated in two ways, that is traditional endodontics or regenerative endodontics. We use traditional endodontics in case of immature apex, wherein we go for apexification. In case if the apex is mature, that is a mature apex is present, we go ahead with root canal treatment. And apexification does not lead to thickening of the dentinal walls in case of immature tooth. It is significant amount of tooth structure which is lost from the traditional endodontic treatment. In case of regenerative endodontics, if we have an immature apex, we go ahead with revascularization procedure, and in case if we have a mature apex, we go ahead with stem cell therapy or pulp implantation or scaffold or gene implantation therapy. This helps in revitalization of the pulp space with functional tissue capable of dentine deposition. So this regeneration is basically a triad, that is with the presence of stem cells or progenitor cells, then scaffolds or extracellular matrix, and signaling molecules or growth factors. The cells which are responsible in the triad could be adult stem cells, progenitor, embryonic cells, autogenous, allogenic, cultivated, mobilized or engineered stem cells. The scaffolds are the naturally derived synthetic polymers, inorganic materials or foams, fibers, gels, membranes or mesh. The signals could be transforming growth factor beta, bone morphogenic proteins, fibroblastic growth factors, WNTs and tumor necrosing growth factors. Let's look into the triad one by one. First one, the stem cells. The adult dental stem cells can be classified into two, epithelial stem cells and mesenchymal stem cells. The mesenchymal stem cells are derived from 6 different sources. That is, it could be derived from the stem cells of human exfoliated deciduous teeth. It could be derived from dental adult pulp stem cells, the stem cells from the apical part of the papilla, which is the scap cells, the stem cells from the dentin follicles, the periodontal ligament stem cells and bone marrow derived mesenchymal stem cells. Coming to scaffold. Scaffolds are basically an artificial structure which is capable of supporting these cells which are implanted into it in a 3-dimensional tissue formation. The scaffolds basically serve the following purposes, which is it allows cells attachment and migration, it delivers and retains cells and biomechanical factors, it enables diffusion of vital cell nutrients and express products, it provides structural support and shape to the construct. The scaffolds can be further classified as degradable of matrices based on foams, based on presence or absence of cells. Based on its origin, it can be either natural or synthetic or artificial. Based on degradability, it is biodegradable or permanent. Based on form, it is solid blocks, sheets or porous sponges or even hydrogels, which is injectable scaffolds. Based on the presence or absence of the cells, it could be cell-free scaffold or already self-seeded stem cell presence scaffolds. Based on the origin, it could be biological or natural, which is PRP, platelet-rich plasma and platelet-rich fibrin, collagen, chitosan, then demineralized or native dentin matrix, even blood clot and silk. In case of artificial, it could be polymers or bioceramics. The polymers are PLA, PGA, PLGA and PCl, and the bioceramics could be calcium, phosphate, bioactive glasses and glass ceramics. Next is the growth factors. Now that we have the cells which is seeded in the scaffold, there is something which we need like a water for it to promote. So these growth factors come into the role play. So the growth factors are basically the platelet derived growth factors, bone morphogenic proteins, transforming growth factor beta, vascular endothelial growth factor, the fibroblast growth factors, insulin growth factors, nerve growth factors and stromal cell derived growth factors. So these are biological factors which regulate the stem cells to form the desired cell type. So as I told you, the platelet derived growth factors are responsible for cell growth or new generation or repair of blood vessels and collagen production. The vascular endothelial growth factors are the factors which help in the promotion of angiogenesis and wound healing. The epidermal growth factors are helps in the promotion of epithelial stem cells, angiogenesis and also wound healing. The fibroblast growth factors which are present in the epithelialization phases of wound healing, and keratinocytes which cover the wound and performing epithelium. The insulin-like growth factors help in cell regulation, cell growth regulations. The transforming growth factor beta are responsible for growth and new genesis of epithelial cells and vascular endothelial cells. It also helps in promotion of wound healing. And the connective tissue growth factors is the one which promotes angiogenesis, cartilage regeneration and the most important, platelet adhesion. Let's get into the clinical workflow. The American Association of Endodontists has given a clinical guidelines for regenerative procedure in 2018. These are the following important criteria for the case selection. The tooth with a necrotic pulp and an immature apex should be present, which is ideal for the regenerative procedure. The pulp space is not needed for post and core or final restoration. The patient should be compliant and the patient should not be allergic to any medications or antibiotics which is necessary to complete this particular procedure. In the first sitting, you will give a local anesthesia, place the dental rubber dam and then do an access cavity preparation. After doing an access cavity preparation, you will do a 20 ml of 1.5% of sodium hypochlorite irrigation. This will be done with a needle which is a close-ended or a side-vented or endovac for 5 minutes. Why close-ended and side-vented is because in case if you push the sodium hypochlorite beyond apex, it might lead to sodium hypochlorite accident or necrosis of the stem cells which is present in the apical region, which is very important for regeneration. After that, you will irrigate with EDTA 20 ml within each canal for 5 minutes. An irrigating needle about 1 mm from the root end. Then you will dry the canals with paper points and place calcium hydroxide or low concentration of triple antibiotic paste below the CEJ level. After this, you will place a cavit or an IRM and GIC and dismiss the patient for 1 to 4 weeks. Next, coming to the second sitting. The patient is reporting to you for the second sitting. In second sitting, you will go ahead with 3% of mepivacaine without vasoconstrictor and then place a rubber dam isolation. After this, you will irrigate the canal with 20 ml of 17% of EDTA and dry with paper points. You will create a bleeding in the canal by over instrumentation or pre-curving a cave file 2 mm past the apical foramen with the goal of having the entire canal with blood till the level of CEJ. After this, you will place an autogenous platelet scaffolds. We saw scaffolds of various origins. You might choose any one, which is optional. After this, you have to stop the bleeding at the level that allows 3 or 4 mm of restorative material. Then you will place a cola puck or a colacate or a cola tape over a blood clot if necessary, using white MTA or even biodentine as pulp capping material. So this is a case of an immature tooth with necrotic pulp. You will use a K file and instrument it beyond the apical foramen to stimulate the bleeding, after which the blood flows into the canal to form a blood clot, over which you will place an MTA and a permanent coronal restoration, and you will wait and observe for 4 weeks, then for 6 months, and also 1 year, and even 2 years of review will be called to evaluate whether the root is being regenerated and if there is a presence of regenerated pulp tissue. So the regeneration has basically 3 different types of outcomes. One is the patient outcome, that is if there is a resolution of diseases, that is absence of swelling, drainage or pain, or the survival of the tooth and its function, and even tooth aesthetics. The clinical based outcome is that there is a radiographic healing which is present, and the radiographic root development and positive vitality responses. The scientist based outcome is histological evidence of complete regeneration. So how do you evaluate? You evaluate whether the tooth is vital based on the sensibility and sensitivity test. You can also evaluate using radiograph. In this X-ray, if you can see, it is an open immature apex. After doing a regenerative procedure, there is the closure of apex, confirming that the regeneration procedure is successful. Thank you. If you have any doubts, we will discuss in the comment section.